Oh, we're recording. Okay, cool beans. All right, hypercalcemia, what does that mean?
Higher than normal blood level calcium, which should be greater than 5.0.
Right, too much calcium. So what's the normal range?
3.5 to 5.0.
A little higher. It's 8 points. This is calcemia. So 8.5 to 10.5. Exactly.
I'm sorry, I was thinking of potassium.
Oh, yeah, they start to sound the same after a while. So this is why I'm just going to mute my phone. This is why you need to make sure that, you know, you get them all, put them in those silos, and you know which one you're talking about. So calcium has the seesaw effect with what? What other electrolyte?
Phosphate.
Phosphorus. Where is calcium created? Where's calcium created?
It is created in the blood and then stored in the
From
bone.
where? How does it get to the blood? So the blood cells are making calcium? Is that what you're saying?
Now, when we eat, the parathyroid hormone and in addition to vitamin D, absorbs calcium from the food and then stores them in the blood, in the bone.
But where does the body make it? We get extra calcium from our food. I will agree with you on that. But where does the parathyroid? So behind the thyroid glands, there's two little glands on each side of the thyroid, and that's where we will have the secretion or production of calcium. So if a person has their thyroid removed, then that individual, you would expect to have some type of calcium abnormalities because their body's not making it, right? And in class, didn't we cover the hypocalcemia?
We did.
Okay, so we would start seeing twitching around the mouth. We would see carpal spasms. We could see laryngeal spasms. This is why that is significant. This can occur when the calcium levels are too low. So we want to make sure that it's within normal range and it's not less than 8.5, because then we're going to have an issue, right? EKG strip, you know, we want to make sure that we look for, you know, abnormalities related to that. Then we talked about the assessment of Trousseau's and Chevestek sign, which are signs of hypocalcemia, right? So one is when you touch the face, then you get twitching. The other one is you put the blood pressure cuff on, you let it sit for a couple minutes, and then what happens?
There will be carpal spasm.
Well, carpal spasms is completely different. I mean, that's usually a kind of a contortion of your fingers. So we're talking about the calcium part, though, where they have Trousseau sign, right? So my question was, what happens at that particular point? Doesn't the hand kind of spasm downward? Is that what you're trying to say?
Yes.
Oh, yeah. Involuntary movements, that is true. There we go. All right. So on the flip side of that, we have hypercalcemia, right? So now the number we would expect to be is greater than 10.5. And so if calcium is made from the parathyroid, would this be a hyposecretion of the parathyroid hormone, or would it be a hypersecretion?
It will be a hypersecretion.
So basically, too much of the calcium is being dumped into the blood or released into the blood. Excessive calcium intake, or vitamin D supplements. Vitamin D helps the body to better absorb calcium. So if we are if we're taking too much vitamin D, then we can end up with an excess of calcium. What about glucocorticoids? How does that affect a high calcium level? So those glucocorticoids, which is the anti-inflammatory, how can that increase your calcium level?
Yeah, I remember that they increase it, but I can't really think of the pathway.
That's because it will suppress, inhibit, diminish, however you want to put it, calcium absorption. So if the calcium isn't being absorbed, we want it in the bones, then it's dumping it out. It's leaving too much of it in the blood. Okay. Hyperthyroidism, which is basically where that hormone's activated, parathyroids are behind it. Calcium excretion is decreased. So the amount of calcium that we are eliminating or excreting out, that's decreased. And you usually see that with someone that's getting thiazide diuretics. You may see it with someone that's in renal failure because they can't get rid of the calcium from the kidneys because they're not peeing. And then if someone has bone cancer, then that's going to be a problem. So that's where calcium excretion is decreased. Which one of the adrenal issues would be seen with hypercalcemia? Would that be Cushing's or Addison's? It'd be Addison's. Thank you. So lithium usage. So how does lithium affect it? Because we talked about that at the end of class. Because lithium does affect the parathyroid. But how does it cause the calcium to increase? This is kind of an indirect process.
I think it has to do with like maybe binding it kind of increases the lithium level, like when the calcium is low.
But we're talking about calcium being high. So this would mean that this is where it could be related to the phosphorus. So the phosphorus is too low, therefore the calcium is too high with the lithium usage.
Okay.
So what would you expect our signs and symptoms to be? We have too much calcium. And remember, they are responsible for nerve conduction and some other things. So what would you expect your patient to present as?
Diminished deep tendon reflexes.
Okay, so they're deep tendon reflexes. Okay, I can see that. They'll be tired, they'll be weak. EKG changes. Is it hypertension? In what way? But it is definitely muscle weakness. Would you have deep tendon reflexes, yes or no?
Will be diminished in
They'll
low
be
calcium.
absent if it's too high. So they'll start to diminish to go, and they'll be that to absent. They'll be absent-minded. They'll have abdominal distension. They could have, and could be from constipation because now nothing's moving. So calcium does have to do with nerve contraction, impulse contraction, kidney stone formation, because now we have too much of it available. It's not being excreted. It can stay in the kidneys, and now you have kidney stones. So things we want to do is to keep them hydrated so that they don't develop kidney stones. Make sure fall precautions because they're going to be weak and tired. We want to monitor the EKG changes, and those EKG changes would be from the Q to the T. That distance is going to be really short, and then their ST segment's actually going to be prolonged, and that would not be a good thing. What about, we talked about foods that are high in calcium. So like our diet, our dairy stuff, right? Yogurts, cheeses, things like that. Spinach, collard greens, those have a good source of calcium. So are we going to tell them to take those?
In high calcium now.
No, they're going to reduce it and or eliminate, okay? So we don't want to, those foods that are rich in calcium, those are the foods that we want them to avoid. We don't want them taking vitamin D supplements because vitamin D helps you to absorb calcium, right? So we're trying to decrease that level. If they're taking calcium supplements, we're going to tell them to stop taking calcium supplements. So for hypocalcemia, we said that, or we discussed that we would give them calcium gluconate. Would this be something we should do here?
No.
No. So we're going to give them a calcium reabsorption inhibitor like calcitonin. So we're going to give them calcitonin, biophosphate, prostaglandin synthesis inhibitors, things like that. So we give, in moderate cases where we have a lot of hypercalcemia, then we're going to give them the calcitonin. In mild cases, we're going to treat with diet, monitor safety precautions for falls, things of that nature. Worst case scenario, dialysis. So that's where it's, it's extremely elevated. And this is a severe case of hypercalcemia. Then we're going to actually eliminate the calcium out of the body by giving them dialysis. So what I would be doing is when I'm looking at hypo and hypercalcemia, I would be looking at what do we do for mild, what do we do for moderate, what do we do for severe? And then whatever you do, so if you are giving them calcitonin, what are you going to be looking for? This kind of goes back to if you're giving someone that 3% sodium, what are you going to be looking for? What are you going to monitor for?
Lab value of calcium.
Say what?
Reduced lab value of calcium.
Right. So we want to make sure we don't swing them to hypocalcemia. So if you're treating for hypocalcemia, you're making sure you don't swing them to hypercalcemia, and then vice versa. So very much like the 3% sodium. So we're treated for hypernatremia, right? But we don't want them to become hypernatremic. So this is why we want to make sure that we're monitoring our processes, that we're not causing a person to go from one electrolyte imbalance to the next electrolyte imbalance. Make sense? Any other questions about the calcium that you can think of, or questions? Because that would close out calcium at this particular time. All right, then we're going to move on to magnesium. So what's normal magnesium level?
1.5 to 2.5.
Okay, but Brenner says 1.3 to 2.3. Just FYI.
Yes, that's another thing, that these books, have various, lab values, like the normal range lab values, even though they differ a little bit. Like I've seen some books in potassium that say it is 3.5 to 5.1, things like that. So there appears to be some slight differences in, some of the figures that are being reported.
So we're going to go by Brenner because that is your gold standard. So anytime you're looking at a lab value, that's what we're going to be looking at. Does that make sense?
Okay.
Okay. And so the other thing to keep in mind is that it's not the design of NCLEX or El Centro, for that matter, to give you a number like 2.4. So if the mag's going to be high, it'll be 2.8 or 3. If it's going to be low, it's going to be 1. Do you see what I'm saying? It's going to be low enough for you to understand this is low. Or it's going to be high enough for you to understand, hey, this is high. So just, don't fret too much over that. However, we're going to start with hypomagnesemia. And what's the role of magnesium? What does magnesium do in the body? What is its one major role? Stimulate the parathyroid. It actually regulates the parathyroid hormone. So therefore, it's going to play a role with calcium and calcium levels. So the release is inhibited with low magnesium. So when the magnesium is low, will the calcium be high or low? It's going to be low. So where phosphorus and calcium are inversely related, magnesium and calcium are directly related. Does that make sense? So where calcium and phosphorus are indirectly related, so when one goes up, the other one goes down, with magnesium, when magnesium's down, you should expect calcium also to be down as well, since magnesium is released by or regulated by the parathyroid hormones. And its job is cell function, transferring and storing energy, metabolizes your carbs, your liquids, your proteins. The other important thing that magnesium does is regulate your blood pressure, which is why in pregnancy-induced hypertension, and when they're looking at preeclampsia and eclampsia, they start looking at magnesium levels, okay? So when your magnesium levels are elevated, what would you expect the blood pressure to be? So if I just told you in pregnancy-induced hypertension or in preeclampsia, what is usually the blood pressure in preeclampsia? Is it high or low?
It's high.
It's extremely high, but we give them magnesium, correct? To correct the problem, correct?
Correct.
Why do we give it? Why do we give magnesium? So that would mean the magnesium level would be what?
Low.
It would be low. And that's the reason why we give it, to balance and lower the blood pressure. So blood pressure and magnesium levels are indirectly related, meaning when the blood pressure is high, the magnesium level is low. When the blood pressure is low, the magnesium level is high. Does that make sense?
Yeah.
All right, magnesium level is absorbed in our intestines and we pee it out through our kidneys. Any issues with absorption in the GI tract, so Crohn's disease, celiac disease, any of those, that's going to affect how much magnesium you're going to take in, which can limit magnesium. Okay? So with too low magnesium, we would expect our blood pressure to be elevated. Causes of low magnesium is, when someone's trying to starve themselves to death, that can happen. Electrolyte issues. So with a low mag, we would have low calcium and hypokalemia. I'm sorry. Yeah, potassium, K. Hypokalemia. So hypokalemia, hypocalcemia, those will be causes of hypomagnesemia. So they would all be low together. Wasting, like you're peeing too much of the magnesium off. So from loop diuretics like furosemide or Lasix, thiazide diuretics, so your hydrochlorothiazides that they put in blood pressure medication, that can also cause you to pee out your magnesium. Medications like cyclosporine, where would you see cyclosporine? What kind of medication is cyclosporine?
It's an antibiotic.
Nope. It's not an antibiotic. It's an immunosuppressant. So folks that get kidney transplants, they're going to be on cyclosporine. So what happens with the cyclosporine is that it will cause the kidneys or stimulate them to waste the magnesium. So it's pretty much like the loop diuretics when you're peeing off water. Okay. I talked about malabsorption, so because it's in the GI tract, and if the small intestines absorb magnesium, if you have any malabsorption issues, then we're going to have a problem with magnesium being absorbed in the kidneys. I mean, not in the kidneys, in the stomach. Good Lord. Let me say that again. So if you have a GI absorption issue, then it's going to have difficulty with magnesium being absorbed in the GI tract. So celiacs, Crohn's, vomiting, those are all things that can affect magnesium not being absorbed in the stomach. Proton pump inhibitors, that can also affect your absorption of magnesium. So your Protonics, your Nexiums, your Prilosec, so any of those medications that ends in prazole, so the omeprazole, etc. What about alcoholism? How does alcoholism affect magnesium? Do alcoholics do a lot of eating when they're drinking?
No.
No, so it's pretty much like starvation, although they're not trying to starve themselves, but it's a lack of food intake. And this will then stimulate the kidneys because you do a lot of peeing when you're drinking too, right? So that magnesium's going out with the urine as well. Acute pancreatitis, and usually most people do that, as we learned previously, that you can develop pancreatitis from drinking alcohol. So it'd be this that whole process. If you have diabetic ketoacidosis, or you give somebody insulin, that can also cause them to lose magnesium. So other things that magnesium is responsible for is neuromuscular excitability. And in hypomagnesemia, so when the magnesium level is low, what would you expect the neuromuscular junction, how would you expect that to respond?
It would be slowed.
Would it be slowed?
Yeah, it would be slowed in terms of nervous transmission.
Okay, so you're telling me you wouldn't have a positive Trousseau sign?
No, there wouldn't be none.
Actually, you would have a positive Trousseau sign. So the neuromuscular excitability is opposite in magnesium than it is in calcium. So when hopefully you wrote down what happens and we just talked about it, hypercalcemia and hypocalcemia. So when the calcium level is low, you get a positive Trousseau sign, right?
Right.
But in magnesium, when the magnesium level is low, this is when you will see a positive Trousseau sign. So low calcium, Trousseaus, low magnesium, Trousseaus. They're actually the same. And it's due to the low calcium levels.
Right.
Okay. All right. So if it's kind of similar to that, then we're going to have irritability. We can have a weak respiratory system. We can have tetany. There's something called torsades de pois, but it's actually spelled little d-e and then capital P-O-I-N-T-E. And some people say torsades de pointus, but it's not really that. However, this is it looks like ventricular tachycardia. But the ventricular tachycardia is almost on an accordion process. So it starts off low, then it gets really, really big, then it gets really, really low, and then the points twist. And when it twists, it'll get bigger, 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 smaller, 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 then the points will twist. Okay. So this goes along with alcoholism. It's an abnormal lethal heart rhythm, but it is not treated with the, electrical activity. It's not treated with epinephrine. It's not treated with amiodarone. It's actually treated with magnesium. The reason why you have this problem is because the magnesium level is low. So this is the best way to fix torsades is to give them magnesium. So the cardiac changes that you would see that would lead to the torsades would be tall T waves, depressed ST segment, or prolonged QT interval. So basically wide QRSs is what we'll display. Would they have Chevestek's sign?
Yes, they will.
Yes, they will. They will have hypertension because we just talked about if the magnesium level is low, the blood pressure is high. They will have hyperreflexia. So those reflexes will be activated, they'll be hyper. Involuntary movements, they'll have some GI issues. Would you expect to hear bowel sounds? And if so, would they be hyperactive or hypoactive? So this means, remember, magnesium would have to be absorbed in the GI tract. If magnesium isn't able to be absorbed, then what?
The hyperactive bowel sound.
They'll be hyper or hypo?
Hyper.
ER or O?
ER.
There's going to be an O. Hypomagnesemia. We need magnesium for contractility. Don't we need, isn't peristalsis muscle contraction?
Yeah, I was thinking of the hyperreflexia aspect of it.
Well, remember, it's the excitability that we're talking about. It's the same as when you have hypocalcemia.
Okay.
Because remember, they have hypocalcemia, which means they're going to have hypomagnesemia, and then what's the last one? What's the last one?
Hypoactive bowel sounds.
Well, they are going to have hypoactive bowel sounds, but remember, low calcium, low magnesium, and low potassium. So the low potassium and the low calcium could be a reason, or either one of those could be a reason why the magnesium level is low. But if we can't get magnesium absorbed into the GI tract, then nothing's moving. There's no contraction because the magnesium level is low. Remember, it plays a role in cell function. So if I don't have enough magnesium, then my cell function isn't appropriate. Right?
Right.
Okay. So if we don't have enough magnesium, then that means our GI won't go anywhere, which probably means we might be constipated. Our bowel sounds are going to be hypoactive versus hyperactive. So the three systems we want to kind of look at, we definitely need to monitor GI. We need to monitor neuro because remember they're supposed to be tired, lethargic, absent-minded. Remember all of those? Respirations would be irregular, right, or weak. And then we're going to monitor all of those cardiac, we're going to monitor the cardiac system because we have ECG changes. Okay, so if your magnesium level is low, then, and your potassium level is low, so magnesium and potassium. If your magnesium level is low and your potassium level is low, which one do you give first? Magnesium or potassium replacement?
You get the magnesium first, and
You
then
give the magnesium first. Why do you give the magnesium first? To get the potassium up?
Because I remember reading that if the both levels are
So it's hard for the magnesium levels to increase if our potassium levels are low just as well. So if we're more, so you have to look at which one are you treating. If you're trying to get the potassium levels up, then you're going to need to get the mag first. If you're trying to get the mag levels up, you're going to have to get the potassium levels up first. Does that make sense? If magnesium is your problem, then it's hard for the magnesium to go up if the potassium's low, because that's one of the reasons why they have hypomagnesemia. Right? The two causes for hypomagnesemia was low calcium and low potassium. So we got to raise one of those in order to get the magnesium up. Now, when you're talking about, the K levels, then we have to give the mag first to get the K levels up. So you have to make sure you understand that dynamics. Okay? Oops, somebody left. Okay, moving on. Does everybody understand that? So if we're looking at a magnesium problem, then we need to get whatever the electrolyte imbalance is that drags magnesium down, we need to get that level up first. All right, so we would give them potassium supplements so that way we can allow the magnesium level to go up, since we're talking about hypomagnesemia. Other things we could do is calcium supplements, calcium gluconate, vitamin D. So all of those would be potentials because we have looked at what caused the problem, which is low calcium and low potassium. So calcium, if it's low, then we boost that up with giving them calcium supplements. Magnesium, so magnesium sulfate IV, monitor magnesium levels. So when they're really, really low, then we're going to, give them mag. If we can't fix it with giving them potassium or giving them calcium. This can also cause hypermagnesemia. So we're going to monitor for the flip side of that. We're going to check deep tendon reflexes because they're going to be absent or diminished. With the mag infusion, so we don't want to switch them to the other side. Place the patient on seizure precautions. We can also give them oral magnesium, but that can cause them to have diarrhea. So that's because the magnesium is too low. And then what kind of foods can we give them? What foods do you know would be, be a good source of magnesium? Foods that are good sources of magnesium. Green leafy vegetables, that has a source of magnesium, just like it has a source of calcium. Legumes, nuts, cauliflower, fish, that's high in magnesium. So you got to know what foods so that you can encourage your patients to, to intake the right thing. So you got to know at least a couple of them to work with. Questions on hypomagnesemia. All right, so we're going to look at hyper, which is the opposite. You can develop hypermagnesemia by trying to correct low magnesemia, so hypo, with mag sulfate administration. But this is less common than hypo. Usually you have people with more hypomagnesium than hypermagnesium. All right. So we can take too many acids like Mylanta, Maalox, Addison's disease. The glomerular filtration rate could be low. So therefore, we're not peeing enough of it out because remember, it's excreted in the kidneys. And the patients, they're really tired, lethargic, but it's more profound. It's like, it's almost like myasthenia gravis, one of those endocrine diseases where, when the enzyme is present in the body, then that person just becomes super fatigued. Deep tendon reflexes will now be absent, where before they were hyperreflexive, now they would be absent and diminished with hypermagnesemia. Blood pressure, would that be up or down? So if magnesium is up, our blood pressure is down. Thank you, Latricia. So the other cardiac problems they could have is if the patient can become bradycardic, or they can have heart blocks. So that wouldn't be good if they have a heart block. Respiratory rate will be more slow, so they can have a respiratory arrest. Nausea, vomiting, weak skeletal muscles, because the weak skeletal muscles is more in the respiratory tract, so their breathing will be impaired, and they can actually go into cardiac arrest. So there's a lot of issues with hypermagnesemia. This is why when we give them mag, we need to make sure we don't push them on the other side. So we're going to look for patient safety because of their decrease in neural status. If they're renal failure patients, then are we going to give them antacids? No, we're not. We're going to make sure we're checking their magnesium levels if they get magnesium, and then we're going to make sure we don't give them foods that are high or rich in magnesium. What can we give them to help excrete, and not just renal patients, just any patient? What can we give normal patients that are not in renal failure to help excrete out the magnesium? Loop diuretics, the thiazides, which were issues for hypomagnesemia. Okay, if they do have renal failure, then they're going to have to do dialysis. That's for sure. The other thing we can do is give them IV calcium to reverse the side effects of magnesium. So we try to put that in a big line, like a central line, and monitor for infiltration when we do that, when we give them calcium. So do we have any questions about hypermagnesemia? I think we've covered all of our, I'm just double checking, abnormalities. And we talked about phosphorus already, correct? Didn't we cover that one on the last Zoom? Anyone's going to answer that question? Yeah, I think we did. We talked about, because I remember talking about the rhabdomyolysis secondary to the electrolyte imbalances will cause muscle necrosis. I talked about that. Check your notes and make sure, but I believe we covered the phosphorus. It was just calcium and magnesium that we didn't get to. And then you have a PowerPoint as well that gives you clinical manifestations that gives you your numbers. It also tells you, you know, what the causes are. So, and we're not doing chloride, so you don't need to worry about that. So all of your deliverables for fluid and electrolytes would be sodium, potassium, calcium, magnesium, phosphorus, and your your SIADH, your DI, and your chronic renal failure. So all the things that will be associated with that: hemodialysis, you know, signs and symptoms of issues or problems, concerns with dialysis, you know, infection, bleeding, etc. At the site, how to check for the AV shunt, making sure it's properly working, peritoneal dialysis, making sure that dialysate isn't dark and cloudy in color. So I think we've covered it all. You guys have any questions? Because I can't hear anybody. Okay. Any questions, Nikki? And I'm not sure who the other caller is, but just any questions?
No questions.
Okay. Latricia's already answered, so I'm just waiting on baby girl here that's on with the iPhone. Or with the, it came through on.
I don't have any questions. Sorry, this is Erica. My kids are loud.
Nope, that's fine, Erica. Just double checking. So, you know, just make sure you guys are setting these up on your flashcards, you know, or you could do line paper and just kind of like I did in lecture, you know, I do squiggly lines because I can't make a straight one, so I make them wavy. And then just compare and contrast. Usually the things that's causing one, if it's hypo, it could be the thing to use to fix it when it's, you know, when it's hyper or vice versa. So those are things you got to, you know, take a peek at to see how they work. But you got to understand how the body uses it, what's their function, and then, you know, how would you treat it? And you have another week to kind of hone it in, because I think Tuesday you should be doing all the coping stuff, right? And hopefully you guys have been looking at, you know, the coping or cognition or whichever, because this is about 16 exemplars. How many of you have done the, I can't think, it's an 85-year-old in Lippincott. There's a case study. I'm actually trying to find it real quick if I can. Give me a second. And I apologize, that's my dog over there moaning and groaning like his life is so hard. Let's see. This is going to be in your Brunner book. And what I'm going to do is share my screen. All right, so you should see the Brunner book, correct? Can you guys see that? Yes, no, somebody say something, thank you. All right, so when you go here, actually, let me go back to, let me back up real quick and go by concept view. And So even when you guys go to fluid and electrolytes, all of those are here. And you can look at videos. You have Lippincott Advisor. You could use that, and that's a very good resource. And I'm trying to find, they have interactive tutorials that you could use to help yourself, get it put together. I'm just going to pick one. Let's start. Let's just go there. I really want to get to the ebook. Okay, so as you guys go through the book, and I'm just going to scroll down, they're asking you questions in here that you should be able to answer. They're even explaining what's the difference between 1 to 4 pitting edema, what's Bronny's edema. So, if you are paying attention to that, but you got to read this book. You're not going to get through without laying your eyes in this book. I thought I had the page written down where this actual case study comes into place, but I want to say it's at the end of the entire chapter. There's an actual case study. So those are all your signs and symptoms. Here's your fluid and electrolytes, things you need to look for. This actually gives you a chart. If you have this loss, this is likely the fluid balance and the imbalance you would have. Those are all things that you need to understand. And you can't give up and say, it's just too much and I can't remember it, because you had spring break to start on it. I've been talking about it for quite some time to kind of get you guys ready. They even cover electrolyte imbalances, so you can even check yourself here. But I'm trying to get to the interactive case study, so just hang tight. But it's like an 85-year-old guy, and they literally walk you through an entire case study. That is awesome. Here's just a scenario for you right there that you can use to test your knowledge base. More Q&A. That goes into your venous port for a central catheter and how that would work, your PICC lines, triple lumens. Metaports. How'd you guys do on that drug test, by the way? No comment? Let me do this real quick. All right, let me go back. Oh, not there. Here. Oh, that was fundamentals. I was like, this doesn't look familiar. I need your med surge, but that started to look familiar. I was like, wait a minute, why are we talking about lines? Oh, there's that DDABP. All right, so we talked about that. Calcitonin, thyroid hormone. All your T3s. Oh, that's hypo. I don't want that one. So this is a 15 something. Let's see if I can find it there. Come on. I wanted to see if we could actually do this case study. That would be helpful. But for some reason, I can't seem to locate it. And then I'll get offline and be like, here it is. I thought I wrote it down, but evidently I did not. All right, so here's sodium, diagnostic findings. Look at all those EKG imbalances that we talked about. So you can see them all in your book. Calcium imbalances, there you go. Treb's text sign, Chaves text sign, Trousseau's sign. Magnesium, we covered that this morning. Covered phosphorus. We're not doing chloride, so stand down on that one. So here you have, it's about time. All right, here's case study. There you go. So this is Mr. Smith. So if you guys will do that case study, then you will be A-okay. Can't keep anything down. He's weak. He's taking a water pill, but not the blood pressure. So this is on Lasix, lisinopril. This is his BP. Heart rate's 116, irregular. He's a little febrile, and he's a little down on weight. He's been vomiting and diarrhea. So you'd expect him to be hypervolemic or hypovolemic? Hypo. Exactly. So then you would start thinking about what type of electrolyte imbalances he would have. So I'm trying to see what page this is on, because I believe there's one more. This is on page 282. So I suggest you do this case study. And I believe there's one more. I think that was it. It was the one on 282, the 82-year-old guy. You guys need to do that case study. Yeah, because the rest goes into your acid-base imbalances. Questions? So page 282, so you can pass that along to your classmates. That will be the case study that will help you with understanding electrolyte imbalances, but it's at the end of the chapter, pretty much what I said already. Okie doke. If you guys don't have any other questions, then we will close it out for today, and we'll see you on Tuesday.
Okay, thank you.
You're welcome. Enjoy your weekend.
I'll try.
You'll be fine. All right, see you Tuesday.